to another ECIST podcast. This session, we're going to be looking at every contact counts. And hello, my name is Kate Pound. I'm a member of the ECIST team, and I'm joined today here by Mike and Margaret. Margaret, do you want to introduce yourself first?
Yeah, thank you. Lovely to be here. So my name is Margaret Khumalo, and I'm a registered health visitor as well as a general nurse, currently working as a community nurse fellow with the National Nursing Team. Thank you.
Brilliant, thank you. And Mike?
Hi, yeah, thank you for having me. So my name is Mike. So I'm a training lead as part of the More Life company. I'm currently working on the One Life Suffolk contract. So I'm based in the east of England at the moment. My background is working on the NDPP, so the National Diabetes Programme, as part of regional supports and training, and now more recently working on the MECC contracts.
Brilliant. So as you both know, today's session is making every contact count. Do you want to tell me a bit more about what is this? What are we talking about today?
Right.
Yeah,
so
I'm happy to.
Okay.
Go on, Margaret. No, go. So I'll kick off. So MECC. So like I said, my role is training and development for the content. So basically, in a nutshell, MECC is about improving the confidence and having behaviour change conversations as it could be a community nurse, it could be as part of being a doctor, it could be anyone can have these conversations, but primary care and secondary care is obviously where it becomes so prominent, and it's about improving our confidence in having these conversations, in creating awareness to change being possible as part of whether it's a patient or a client, and just encouraging those changes and supporting that kind of journey that people go through, basically.
Brilliant. And Margaret, from your viewpoint, maybe you could tell us a bit about what it means to you, but also some examples of, real examples of when you refer to patients.
Yeah, sure. Just adding on to what Mike has already said. I mean, it's an evidence-based approach, which is really about improving people's health and well-being by helping them change their behavior. So this could be about kind of lifestyle things. So through those conversations that we already have. So for us, it's not really about additional kind of meetings but actually capitalizing on the contacts that we already have with patients. And of course, an NHS long-term plan reminds us that we have 1 million contacts every 24 hours with patients. And so it's an opportunity for us to use those contacts through kind of, brief or very brief conversations to really talk to people about maybe it could be risk factors such as alcohol, diet, physical activity, smoking, and mental well-being.
And why is it important to you, Margaret?
Well, at the moment, considering the current sort of economic crisis that we're having, the issues with the health service not being able to cope very well with people going to hospitals, sometimes for kind of needs that are not necessarily needs that need to be dealt with by the hospital. So it is important that we as professionals that are already seeing our patients really capitalize on those conversations that we're having with patients to understand what else is impacting on their health outcomes beyond that sort of clinical presentation. So it's really important that we build those rapports with our patients and really understand. We know, for instance, in the pandemic, that a lot of patients were impacted, had additional kind of needs that they were having to deal with, whether they were health needs or maybe other kind of health inequalities, as we call them, those kind of situations that create the differences in the outcomes that we get in our health. So what we're saying is, let's be mindful when we are seeing patients and really use those conversations that we have with them to understand what else could be impacting on their health. Is it the food kind of poverty? Is there anything else going on about hitting poverty that could end up driving patients down to kind of urgent and emergency care? Whereas if we kind of link them with our services and support that we have in the community, then we kind of stem that flow of patients going to urgent services unnecessarily.
Mike, from your viewpoint, as the person that's delivering the training, why is this so important?
I think it's, again, similar to what Margaret said. I think it's just reiterating more often than not the positives that we probably already do in these conversations, and sometimes just reinforcing those ideas. And because it can be very easy, you come out of a conversation with a patient or a client thinking, did I do the best I could have done in those situations? Reality is probably we do most of the time, but there's always probably an opportunity to maximize those potential opportunity. Again, it's about sowing that seed potentially where they might not want to make that change at that very point in time, but it could be 6 months later. If we've had this healthy, open conversation and not been prescriptive, then 6 months down the line, when things align, their priorities align to making that healthy behavior change, then they're going to come back to us and they're going to say, you know, we spoke about this before. I'm very keen to make this change. And it's getting those messages across, because if we have that prescriptive approach, it can close doors immediately, and we can lose patients in 20 minutes. So giving that opportunity for the future is so key, and that's obviously what we're trying to incorporate with the MECC training, take on board health literacy, health equity, health equality, all these different aspects which are so key to these conversations, really.
And that leads me into the next question, really, Mike, and that is, what are the benefits of Make Every Contact Count with the training to patients, staff and organisations?
Yeah, so starting with patients, it's creating an awareness. So in various ways, awareness to maybe what their current health is. We all have busy lives, and especially with everything we've experienced, it's very difficult to take a minute to yourself and think, how am I? We don't consider these questions until we go and speak to someone, or like health checks, or go to your GP, whoever you like to go and speak to about your health. We don't have that time to consider for ourselves. So it creates that awareness. And again, my background being an NDPP, many people don't know they're maybe on the risk of diabetes, for example, type 2 diabetes. So to have someone say, are you aware of this? And then asking the questions, how does it make you feel? How can I help you with these results? Is there anything you want to discuss at this point? Because it'd be very easy to assume, okay, these are your results, this is what you should do now. Yeah, there's probably a degree to that, but we need to consider their background, their experiences. How are they feeling? Is it something they want to talk about right now? Is it something they want to talk about maybe in a couple of days when they've had a time to consider it to themselves? So again, all those considerations are so important. So that's from a patient's aspect. And then staff, again, it helps us when we talk about having more of an awareness of signposting, what's available, integrated care, which is obviously something I think probably nationally we all can work towards, because it's about that journey of the patient, because we're only just one small chink in that cycle of change that they're going to be going through. So if we're aware of what's available, it gives us confidence to go into a difficult conversation. Community nurses, you can never assume what a conversation is going to be like. It's going to be different, one person to the next, whoever they're visiting, and it's like that for any primary secondary care. So to have knowledge of what is available is just so imperative. We use MECC links as a source of signposting, which has been very interesting to be a part of, because you learn about so many services. I think I had no idea that existed, but that's really good to know. So if we don't know, general public isn't going to know. So again, but then it also helps us have confidence to delve into the difficult conversations. And then obviously that builds into the organisation. Margaret mentioned earlier, the stresses and the pressure of emergency services. On average, I think I was reading earlier, there's about 36.1 million GP appointments were made in October. You think of all those opportunities that are there. In the perfect world, let's say we had everyone was in a successful MECC conversation, the amount of pressure and being proactive in those conversations would have made, instead of being reactive when people are going to emergency services, it would have made a huge difference in the perfect world, obviously. But again, creates that opportunity to improve on supporting emergency services, and obviously that can feed to more improvements and support down the line. So yeah, it supports everything, really.
Thank you. And Margaret, you've obviously done the training. So how have you seen that impact in your world?
Yeah. So as a health visitor, it was always important when you looking at your clients to almost be, in some ways, anticipate what they might need, have a discussion with them, obviously personalizing to understand what matters to them at that point. So, for instance, it was a patient that I could be visiting, and I might, she might indicate she's got symptoms of something, and I could check her blood pressure and then actually notice that maybe blood pressure is a little bit raised. So it was also really about raising that awareness, which is something that Mike already touched on. But it was really about making that contact effective at that point. So making sure that I'm not saying to her, go and see your GP for a blood pressure check, but actually that I have that equipment at that time. And actually I can call the GP to say, I'm in Mrs. So-and-so's house and I've just checked her blood pressure and I'm just a little bit concerned. I've given her some advice, but it's something that you can follow up on. So making every contact count can be about things that we already know about, that we're supporting patients with, or it could be that we actually raise an awareness of something that they were not even aware of themselves that they have. But it is also about understanding where they are, as Mike already talked about, that you can lose a patient if you become prescriptive about how they should deal with that new problem that they might get to learn about first. So we understand, of course, from the global burden of diseases that which tracks the kind of premature death, causes of the premature death in different countries, that actually in the United Kingdom at the moment, we've got high blood pressure, poor diet, obesity, smoking, alcohol, and drug misuse, as well as lack of exercise and air pollution as those really key issues that we need to deal with. And when you think about making every contact count, those are the kind of competencies and skills that we are really empowering our workforce with. But obviously, when you're then talking to your patients and also empowering them to understand, what they can do to help themselves, I mean, that's a win-win for our patients. We're improving that health literacy. We're identifying a need, and that adds on to the other things that we're supposed to be doing now, really working, identifying our needs in our population early, to really have that upstream prevention and then be able to manage conditions before they become serious and then needing that sort of urgent and emergency care. And we are also really supporting the system in highlighting where the need is. And so I know, for instance, Mike, you could probably tell us a bit more about the data that you collect on the sort of services that are being utilized more by, through your MECC link. That should really help us to understand where the need is and also where we can commission more resources depending on what we're seeing on the ground. So
I guess to me as well, it's that kind of like it's going from, you're not just doing an action with a patient, you're actually building that relationship, and through making those contacts count and making the patient feel safe in your environment, that you're happy to have these conversations, and that's got to be a big help. So how do people get the training? Who wants to speak first? Michael, Margaret?
I'll go for it. So for me, I'm based in, obviously, like I say, Suffolk currently, and do a lot of work within the Suffolk area. So we generally provide training predominantly face-to-face or virtually, for the reason we believe that we want to encourage these conversations amongst colleagues. So as well as open sessions where we invite different sectors to meet up and we deliver the training, because it gives an insight to different types of conversations that occur and how can you have these different types of conversations. Because if there was a one size fits all, here's a script, we probably wouldn't be here. This would be a completely different story, but that's not the case, unfortunately. So it's been fascinating to have these different types of training and meeting different sectors and what types of conversations they go through. And as well as digital, so we provide a digital version as well, which is more used as a refresher training source. So it's nice. Again, we do with everyone's experiences. Everyone has lots of conversations. It implements probably MECC training without probably recognizing they implement MECC training more often than not. So the digital version is there to kind of refresh key learning points, like I said, health literacy, health equity, key points like that. So yeah, we provide a variety of services. Lots of changes can be adapted to improve. We want to implement trainer programs. So we go to services and train people within so that they can deliver the training internally, which I think will be a great asset, because then they can relate a lot more to other staff members and say, I've been through this, they can experience it themselves. So yeah, there's many ways this can adapt. So, but yeah, face-to-face and virtual is a great form of delivery within the MECC training.
So, Margaret, I'm a ward nurse or a community nurse. How do I get my name down? What do I need to do?
Well, I would say the first thing to do is to probably access the e-learning for health portal, which is hosted by Health Education England. So on there, you will find MECC training, the online version that is there, which has been the one that we have been really pushing at the moment because of a whole range of issues, especially the pandemic. But also ask your training department, because we know some community trusts and acute trusts have got in-house training. So Guy's and St. Thomas's, for instance, have that. We have the same in Central London Healthcare Community Trust. So we know of trusts that have already that in place. And also just the local authorities. They're very big on MECC as well. We are now working as integrated care systems. So if they are offering training, I don't see any problems in somebody asking if they could access that training, because actually the more we can do this sort of integrated, sort of build different teams working, we can really understand, as Mike has already highlighted, the different perspectives that we can come from in really sort of identifying those needs. However, we do know that there is patchy kind of provision right now in terms of training, which is why we have been trying to do this work with Mike to try and see if we can just run a few sort of short webinars kind of typed training sessions, just to really kind of do a reminder session, to just say to people, this is MECC, but also to really highlight where they can get support for people, especially that MECC link. Would be really fantastic to push to people, because not everybody knows about it. But what it does help us with is that data. It helps us to collate the data so that actually we can understand where are the needs, and then we can really try and influence our commissioning decisions.
So in short, if you haven't got the training locally, why not think about get the training, and you can then be the trainer for your organisation.
That's another one. Yeah, perfect.
Just as we come to a close, I'm going to ask you both of you a short statement of why should we do it? Why are you shouting about this? So just one short sentence on why this is important to you.
Wow. I mean, for me, making every corner count is that it? It's how are you making that contact, that insight, that opportunity that you have with that person in front of you. Absolutely. To really support them, to really get the best out of, whatever their situation is, so that they can really live their best lives, and, we can really support them with whatever issues that they're having. It might not be issues, they might just need a little bit of information or whatever the case is. So I think it should be everybody's business, really.
So basically, it's never just a flu jab.
No.
It's a flu jab with.
Yeah, something
brilliant.
else.
And
yeah.
Mike?
Yeah, I think for me, we can all relate to a situation when we've had maybe a bad conversation. I think we could all relate to a situation. And then I think there will be times when we think, I wish now someone spoke to me the way I'd like to be spoken to. So I think with MECC, that encourages that. I think if we can come away and the patient goes away thinking, oh, I had a really good conversation, I feel confident where I am, I know what I need to do, it can make the world of a difference to, like Mike was saying, to have the opportunity to live the best life possible. So I think that's what MECC is basically all about, just to create those opportunities, really.
Well, thank you both for your time today. Really great conversation, and I look forward to hearing more in future. So thank you.